A very good morning to one and all present here. Knowledge is like money. To be of value, it must circulate. And in circulating, it can increase in quantity and in value. We warmly welcome each and every one of you to the most awaited CME on recurrent pregnancy loss. This CME is organized by the Department of Obstetrics and Gynecology in BLDE Dept University in collaboration with Vijayapura Obstetrics and Gynecological Society. Recurrent pregnancy loss has been inconsistently defined as 3 consecutive pregnancy losses prior to 20 weeks of the last menstrual period. Spontaneous pregnancy loss can be physically and emotionally taxing for couples, especially when faced with recurrent losses. Henceforth, we hope that today's CME on recurrent pregnancy loss will help us to enlighten our knowledge and provide safe, quality, and comprehensive care to our patients. We welcome all the eminent speakers, chairpersons, and the guests to this wonderful CME. Today's CME shall start with a session on genetics in recurrent pregnancy loss by Dr. Shri, Associate Professor, Department of Obstetrics and Gynecology, BLDE Dept University. I request Now I request Dr. P.B. sir, Senior Professor, Department of Obstetrics, BLDE, and Dr. Shri ma'am, Senior Consultant, Past Board Secretary, Vijayapura, to chair the session. Now I request Dr. Shri ma'am to introduce our speaker.
Good morning, everybody. I welcome our speaker, Dr. Shri, to speak on the topic genetics in recurrent pregnancy loss. It's a common topic. Good morning, everybody. I welcome our today's speaker, Dr. Shri, to speak on the topic genetics in recurrent pregnancy loss. It is a common cause for recurrent pregnancy loss in the first trimester, accounts for about 75% of the cases. It is my great privilege to introduce our speaker, Dr. Shri, Associate Professor in the Department of OBGY, Shri Patil Medical College, Vijayapura. She is a very hard-working lady and joyful, and she is working since many years in this department. And she is with a qualification MBBS, PGO, and DLD. Her publications in national and international journals. She has given few original articles in various journals. Presentations like paper presentations and posters in state and national conferences. She's been invited to the national and state conferences and regional conferences. And field of special training is ultrasonography in pregnancy, laparoscopy, and infertility. Her areas of interest are teaching, high-risk pregnancy, and management. So I would like Dr. Shri to continue.
Thank you, ma'am. Thank you for the nice introduction. I would like to start the topic of genetic causes of recurrent pregnancy loss. So, as already told, 3 or more clinically recognized pregnancy losses before 20 weeks of conception. It affects 1 in 300 couples. But American Society for Reproductive Medicine reports suggest to evaluate the couple after 2 or more miscarriages, and this occurs in around 5% of the couples trying to conceive. Primary recurrent pregnancy loss refer to the couples that have never had a live birth, whereas secondary recurrent pregnancy loss refers to those who had a repetitive loss following a successful pregnancy. The main causes for this are genetic causes affect around 3.5 to 5%, anatomical causes account for 12 to 16%, endocrine causes account for 17 to 20%, infectious factors accounts for 0.5 to 5%, and around 20 to 50% are because of the immunological factors. So the main factor, genetic factors that account for recurrent pregnancy loss are parental genetic abnormalities, mainly reciprocal translocations in that account for 59%, Robertsonian translocations account for 27%, and chromosomal inversions account for around 9%, and aneuploidies are seen in around 4% of the cases, and supernumerary chromosomes account for around 1% of the cases. So the main chromosomal or parental chromosomal anomalies occur in around 3 to 5% of the couples in patients with RPL, whereas in general population, the chromosomal anomalies seen are in the parents is around 0.7%. So the main chromosomal anomalies seen are the translocations, inversions, ring chromosomes. In the translocations, balanced translocations are the most common chromosomal abnormalities contributing to the recurrent pregnancy loss. In that only again, Robertsonian translocations involve 2 exocentric chromosomes, that is 13, 14, 15, 21, 22, that fuse near the centromere region with loss of the short arm. One of the example of Robertsonian translocation is the case of Down syndrome, where from 14 chromosome 14, 21 is attached, so that extra chromosome will be there. Trisomy 21 will get formed in that. Whereas in reciprocal translocations, the type of rearrangement result from breakage of non-homologous chromosomes with reciprocal exchange of broken off segments. So this is the picture showing the ring chromosomes. Okay, it is one of the abnormality where the fetal losses can happen, or even if the child is born, it will be of the mentally retarded. This is example of Cry-Duchat syndrome, where part of a chromosome 5 is deleted. Most of such fetuses, if they are developing, they will get aborted, or even if they are born, they'll have retardation, and even the infant cry here sounds like a high-pitched cat meow. This is like one example where chromosomal deletion has happened. Even the translocations where exchange occur between non-homologous chromosomes. So this is the example where chromosome number 3 and 4 are part of the chromosome is exchanged in between chromosome 3 and 4. So what happens with these pregnancies? Whenever such exchanges can happen, either the fetus will be malformed or the fetus will get either it will go for the miscarriage. So what we should do for such couples when they have recurrent pregnancy loss, what we can offer them? So whenever we see patients with 2 or more pregnancy losses, we can offer them to undergo genetic testing of the products of conception. So this genetic testing in one of the study, the aneuploidy screening, one of the study they have done where almost 90% aneuploidy is seen between the products expelled less than 6 weeks of gestation. So most of the blighted ovums or less than 6, they are because of the genetic causes, whereas around 50% genetic causes between 8 to 11 weeks, and it decreases almost less than 5% once the fetal cardiac activity appears. So once the fetal cardiac activity appears, the causes will be like either thrombophilias or thrombotic disorders, or as madam will be speaking about the APLA causes once the fetal. Whereas before the fetal cardiac activity appears, the main causes are the genetic problems. So what we should do, karyotyping, karyotyping of the product of conception has to be done. Karyotyping, it involves the culture of the cells, Giemsa staining of the cells which are arrested in the metaphase, and analysis of the binding patterns for both numerical and structural errors. But there are some limitations associated with karyotyping, like culture failure that occurs in almost 10 to 40% of the cases, and maternal cell contamination can occur. And usually if the resolution is less than 10 millimeter, 10 MB, the minor genomic changes may not be detectable. So one more technique that has been developed recently is the comparative genomic hybridization, where it compares the control DNA and the DNA extracted from the miscarriage tissue. These are labeled with the fluorescent molecules of different colors, and they are hybridized in 1:1 ratio as a set of normal metaphase chromosomes. In that, again, they will compare normal and abnormal chromosomes. The abnormal chromosomes will appear as increased fluorescence pattern that will be seen. Then again, a computer analysis of the microscopic images of the hybridization compares relative fluorescence intensities, and that will identify whether the chromosomal pattern is normal or abnormal. One more thing, what we can offer for the couples who are having recurrent is the parental genetic testing. So that can be done either by the peripheral blood karyotyping, okay, or and also we can discuss with the couples about transmission of the identified abnormality to the offsprings and their chance of future pregnancy loss and the possibility of delivering a live affected child. So the known carriers of structural chromosome abnormalities and some with single gene defect, also they can proceed with the, so what we can offer them, suppose they have, we have identified chromosomal problems in them, then we can offer them assisted reproductive technologies, like they can go for artificial assisted ART with the pre-implantation genetic diagnosis of the embryos. So one of the treatment we can offer for patients with recurrent pregnancy loss and identified genetic abnormality is the pre-implantation genetic screening. That can be done either by taking the blastomere biopsy or by taking the blastomere biopsy is taken and cells are again arrested in the metaphase. Then we are going to identify any chromosomal problems. Then we can go for the implantation of the blastomeres, or we can offer them polar body biopsy or trophoectoderm biopsies. So the conclusions of this are: genetic variables appear to play a complex role in efficiency of human reproduction. Classically, the high rate of chromosomal errors have been among the leading etiologies for fetal loss, and specific single gene defects may play a pregnancy maintenance. Overall, the prognosis for a patient with RPL is good, and most women with history of RPL are likely to miscarry, less likely to miscarry in the next marriage, but they have more chance of delivering a live baby. So to help couples struggling with RPL, limited and focused genetic testing is recommended as part of the diagnostic approach. Pre-implantic genetic diagnosis may be indicated in small proportion of the couples with defined translocations or selected single gene disorders. Thank you.
Thank you, ma'am, for your knowledgeable lecture. Now we shall continue with the lecture on antiphospholipid antibody syndrome by Dr. S.R. Bidri, ma'am, Professor and HOD of Department of Obstetric and Gynecology, BLDE, Vijayapura. Now I request Dr. P.B. Jaju, sir, to introduce our speaker.
Good morning, everybody. It is my great pleasure and honor to introduce Dr. S.R. Bidri. He is known to everybody in this institution Is very popular physician and famous teacher. She is hardworking, is kind-hearted to patients and students. She has done MBBS from Jain Medical College, Belgavi. She has done MD from BLDE University. Yes. She is now working as professor and head of the Department of Physics and Gynecology, BLDE Medical College. She has worked in many international projects conducted in BLDE institution. She has conducted many hidden checkup camps by inner being club of JSA. She has got many awards, among the two, awarded as Senior Scientist Award by BLDE University and Award of Women in Science. She is awarded as Best Doctor Award by Rotary Club of Vijayapura. Here I present most dynamic, most active and smiling Dr. Shailja Bidre Madam. I invite her.
Thank you, sir.
To talk about antiphospholipid antibody syndrome.
Thank you, sir, for your kind words. Good morning, everybody. So, greeting from BLDE University. Today's topic is APLA. I'm going to talk on that. Before that, there are three issues in recurrent pregnancy loss. That is, one is already Madam has talked, Shobha Madam, very elaborative genetic causes, less than 6 to 8 weeks. And now I'm going to talk on recurrent pregnancy loss due to APLA, antiphospholipid syndrome. And the third one is going to talk by Dr. Jaideep Tang, that is Luteal phase defect. Today, it is a definition. Antiphospholipid syndrome is an autoimmune disorder characterized by arterial and venous thrombosis, adverse pregnancy outcome for both mother and fetus, raised levels of antiphospholipid antibodies. Epidemiology: 1 to 5% of the healthy individuals have antiphospholipid antibodies. Incidence about 5 cases per 1 lakh persons per year. 50% of the antiphospholipid syndrome cases not associated with another rheumatic disease. It is one of the common factor for antiphospholipid antibody syndrome. Antiphospholipid syndrome found in about 30 to 40%. 1/3 of the recurrent pregnancy loss can be due to APLA syndrome. This is a pathophysiology. Antiphospholipid antibodies affects on the platelet, activate the platelet aggregations, coagulation cascade, inhibits the protein C and protein S, thrombomodulin, antithrombin 3 fibrolysis, and endothelial cells become increases the TF adhesions molecules and pro-inflammatory cytokines. Placental tissues are decrease the thromboplastic cells, grown increases the apoptosis. APS criteria, antiphospholipid syndrome criteria, Sydney reversion of the SAPRO criteria, definition. They are classified into clinical and lab investigations. How to confirm the antiphospholipid syndrome? Vascular thrombosis, arterial or venous, pregnancy morbidity, 1 or more death in a normal fetus, less than 10 weeks. That is more important. Early pregnancy with a 6 to 8, less than 6 to 8 weeks. Most of the time it is a chromosomal. Next, less than 10 weeks, we have to think about the APLA syndrome. And 1 or more premature birth, less than 34 weeks due to severe preeclampsia or placental insufficiency. Then less than 3 consecutive abortions. It is a very, very disappointing to a woman who has come with a recurrent pregnancy loss, 3 or more losses. Even obstetricians have a lot of stress to continue the pregnancy, how to treat the patient. It is a very, very important. Even obstetricians have a lot of stress to treat the patient who has come with a 3 or more consecutive recurrent losses. Other causes should be ruled out before less than 10 weeks of pregnancy. Lab criteria are anti-cardiolipin IgG and IgM and lupus anticoagulant, anti-beta-2 glycoprotein 1 and IgG and IgM. Positive test should be repeated every at least 12 weeks apart. After 12 weeks, again you have to repeat to confirm your diagnosis by clinical or laboratory. Thrombotic complications, thromboembolic, this is deep vein thrombosis. Most of the time patient come with a deep vein thrombosis, that is also very distressing. And pulmonary embolism, transient ischemic attacks, cerebrovascular accidents. That is, venous complications are more than the arterial. Obstetric complications are recurrent pregnancy loss, 25% of this, and out of 100%, and pre-eclampsia 15 to 20% with the APLA, and IUGR, intrauterine growth restriction, and preterm labor, catastrophic APS, that is antiphospholipid syndrome. Here in this case, this is a devastating, rare but devastating in pregnancy, characterized by multi-organ, multiple simultaneously vascular occlusion in the body that finally leads to death. This is the very complication of, means most complicated issue in a APLA syndrome. Diagnosis: multi-organ involvement more than 3, showing acute thrombotic microangiopathy with a micro circulation. Renal affection is the most common. 80% of the failures due to APLA is 80% with the renal, and 30% other 30% of patients will require dialysis. Hypertension is usually present. Treatment parties' primary goals are optimizing the prenatal outcome by reducing the risk of pregnancy loss, placental insufficiency, preterm delivery, and preeclampsia. These are the major issues where to treat the patient, keeping in that APLA is positive. Then to reduce the risk of thrombosis in pregnancy. Heparin, you have to start with the heparin once it is diagnosed as an antiphospholipid syndrome without prior thrombosis. We have to confirm that the past history of any thrombosis was there or not. Then recurrent early miscarriages. In that conditions, unfractional heparin 5,000 to 7,000 international units subcutaneously 12 hours apart. Low molecular weight heparin, that is enoxaparin 40 milligram or deltaparin 5,000 units subcutaneous once daily. Enoxaparin 30 milligram or deltaparin 5,000 units subcutaneously 12 hours apart. These are the regimes we are going to follow for a antiphospholipid syndrome. Then fetal death more than 10 weeks or prior delivery, less than 34 weeks, you are considering due to severe pre-eclampsia or placental insufficiency. One can think about the APLA to treat. Unfractional heparin 7,500 to 10,000 units subcutaneously 12 hours in first trimester, 10,000 subcutaneous also you can treat with a single dose. 12 hours apart in the second and third trimester. In case of 8 to 12 hours, adjusted to maintain the mid-interval partial thromboplastin time 1 to 1.5 times the control mean. Low molecular weight heparin also you can give enoxaparin 30 milligram, deltaparin 5,000 units subcutaneously 12 hours apart. Antiphospholipid syndrome with the thrombosis, already confirmed thrombosis already in the past history. Then you have to go for the unfractionated heparin, that is 8 to 12 hours adjusted to maintain the mid-interval APTT or heparin level anti-XA activity in the therapeutic range. Low molecular weight heparin, weight adjusted according to the weight of the patient. Example, enoxaparin 1 milligram or deltaparin 200 international units per kg subcutaneously 12 hours apart for the monitoring of the anti-XA activity. Antiphospholipid syndrome, pregnancy with the thrombosis or those with the prior pre-eclampsia should be given thromboprophylaxis. This is usually you will follow this thromboprophylaxis. Most of the time patient has given the past history of pre-eclampsia in a postpartum period at least 6 weeks by starting warfarin. Warfarin will be safe during lactation also. In other medications used are corticosteroid, prednisone, low dose heparin, or IVIG not recommended as it is not safe during it causes a preterm labor in a premature delivery also. How we are going to manage? Management strategies are in a woman with the antiphospholipid syndrome, pre-pregnancy levels of APLA should be estimated. We have to assess the APLA level and various maternal obstetrics and heparin therapy risks should be explained to the patient. Very, very important to counsel the patient for the what is the outcome of the APLA. Then women should immediately report if if they miss their periods, because we have to start the OPLA treatment early as once the cardiac activity is noted. So an early TVS should be conducted to confirm the pregnancy, and anticoagulation should be started as soon as the cardiac activity is noted. So only transvaginal ultrasound has a role in this case, and early is the best to treat the APLA syndrome. ANC visit should be at least every 2 weeks, every fortnight till 24 weeks, then weekly. We have to follow the patient very cautiously regarding the outcome. At every visit to monitor pre-eclampsia, thrombosis, and fetal well-being. Serial USGs are compulsory to monitor whether it is a patient, baby's growth and IUGR or oligohydramnios. We have to assess serial ultrasonography. Antenatal fetal surveillance in the form of daily fetal movement counts weekly on non-stress test. NST should be taken, and AFI measurement should be initiated at 30 weeks to 32 weeks or earlier, because we have to assess whether oligohydramnia, IUGR, all these things, USG will help. During labor and delivery, antiphospholipid syndrome patients should be considered at high risk for preeclampsia, uteroplacental insufficiency, and hence continue the electronic fetal monitoring recommended throughout the labor, because we have to monitor strictly regarding the monitoring. Anticoagulant dosing should be altered in order to minimize the risk of bleeding during delivery, as well as not increasing the risk of thrombosis. We have to overweigh. We have to balance both regarding the bleeding as well as to avoid the thrombosis. Patients on thromboprophylaxis, heparin should not be given heparin following the onset of the labor. We have to stop the minimum 24 hours earlier than the cesarean section or delivery. You have to stop because of the PPH. Bleeding will be more. Or in patients who are fully anticoagulated or the APTT is prolonged, protamine sulfate should be given to reduce the risk of bleeding. The American Society of Regional Anesthesia recommends the needle placement, that is a spinal or any epidural. We have to withhold the until 24 hours after the injection, last injection when heparin is continuing, and low molecular weight heparin or adjusted dose of anticoagulant with the unfractionated heparin. In patients on low dose thromboprophylaxis, the American Society of Regional Anesthesia has recommended needle placement to be delayed 12 hours after the last dose. Anticoagulation should be resumed 6 hours after the vaginal delivery or 12 hours after the, because we have to avoid the complications like deep venous thrombosis, thromboembolism, and other complications. Should be adjusted to achieve the INR between 2 to 3. Warfarin should be used for anticoagulation prophylaxis and continue for at least 6 weeks postpartum. Warfarin and heparin are safe in lactation. OCPs are contraindicated in this APLA syndrome postpartum. Thank you. Thank you. I would like to thank Box and BLDE University for giving me the opportunity to talk on the dais. Thank you.
Thank you, ma'am, for your enlightening lecture. Now I request our chairpersons to hand over the e-certificates and bouquet to Dr. S.R. Dept ma'am and Dr. Shobha Sharabur ma'am as a token of appreciation. I thank Dr. K.T. Chaju sir and Dr. Jayashree Sajana ma'am for chairing the session. I request Dr. Mutlu sir, Professor Department of Obstetrics and Gynecology, BLDE, Dept University, to kindly hand over the e-certificates and bouquet to our chairpersons as a token of respect.
Online now, we're starting that. Zoom link is on. Madam, join ಆಗ್ತೀರಿ madam. ಸ್ವಲ್ಪ ಅರ್ಲಿ ಸ್ಟಾರ್ಟ್ ಮಾಡ್ತೀನಿ. Madam is there. Madam.
Inauguration.
There is inauguration. You call them. They will go.
Now I request Dr. Sangesh Matapati sir, Associate Professor, Department of Obstetrics and Gynecology, Shri B.M. Patil Medical College, to take over this session. Thank you.
Good morning, everyone. On behalf of Vijayapura and BLDE University, I would like to invite all of you for this inaugural function, the very CME of recurrent pregnancy loss. It's indeed an honor and privilege to part of such an informative CME. Well, for today's inaugural function, we have our own beloved Dr. Asha Nirvi Madam as our chief guest. Asha Madam is presently the professor and head of the Department of OBGY at SDM Dharwad Medical College. Madam is a very popular teacher and administrator, as we all know. We welcome you, Madam, for this inaugural function.
Thank you. Thank you.
Before moving on, I would like to request Dr. Asha Nirvi Madam to say a few words.
Good morning, and I bring greetings from SDM Dharwad. I'm thankful and honored to be a part of the CME. And RPL is a very common, not so common, but 1% of the all pregnant women, all women we can, this is by incidence. And we should know what are the etiologies and pathophysiology and management. And all the faculties, what I heard last half an hour, very nicely enumerated the etiologies. And I think I'm eager to listen from the other faculties, and I wish success for your CME. Thank you once again for inviting me as a chief guest. Thank you once again.
Thank you, Madam. Well, we are honored to have Dr. Jaideep sir as our guest speaker for today's CME. Sir needs no introduction. He's working in the field of OBGY for the last 2 decades. A very popular speaker and a teacher, and also a strong leader, holding various administrative positions at national and international levels, representing the physicians. on the various platforms. We welcome you, sir. Dr. Tobi Madam would like to speak 2 words about cancer. Share ಮಾಡ್ರಿ. No problem. ಮೇಲೆ. Yes.
Very good morning to all, and really I am very happy and privileged to welcome our beloved Dr. Jaideep Tang. I know him since ages. Every time I visit Foxy office, he is the person who is always on the dais and very active Foxyan. We all know his contribution to Foxy as a Secretary General or whatever post he has taken, Mumbai OBGY Society President, and I have seen his conference. We have witnessed Tanks, his fathers in their father's name, Dr. Parikshit Tank and Jaideep Tank had done wonderful conference. And we know his administrative capacities. We know everything about him. He is a true academician as well. And whenever, as a Food, Drugs and Medical Surgical Equipment Committee, Foxy, as a chair, whenever I wanted his guidance, he has wholeheartedly supported my all programs. He has guided me in many ways so that I could succeed in my committee programs. So to introduce to our BOGS, that is Vijayapura OBGY Society, to Dr. Tang sir, I wish to say our society must be, we started in 1998 and I am the founder member as Dr. Mudnuris. So there are many members in the audience, Dr. Kodhu, Dr. Shobha and others. I cannot take each and everybody's name, but they have contributed a lot to build up this Vijayapura OBGY Society. So we came a long way and we conducted very successful Karnataka state OBGY conference, though it was a very small place. We conducted it very successfully. We had more than 1,000 delegates. And there are 2 medical colleges, there are many professors, there are various academicians in the city. And to the Foxy, we have contributed a lot. We have got many publications. They have got a research unit also, Dr. Shailaja Bigri, who is now heading the department here. She has got WHO collaborations and they have done many things here as a research. So Dr. Jaideep Tang, I want to say to our audience, is a past Secretary General, Federation of Obstetrics and Gynecological Societies of India, project lead, Foxy, USAID projects from 2020-24, past President, Mumbai OBGY Society, Deputy Secretary, Asia Oceania Federation of Obstetrics and Gynecology, immediate past Chair, International Federation of Obstetrics and Gynecology, that is FIGO Committee for Safe Abortion, past Chair, Publication Newsletter Committee of AOPOC, past Chair, Reproductive Endocrinology and Infertility Committee, AOPOC, past Chair of MTP Committee of Foxy, and he has been awarded FRCO honorary in 2020 by Royal College of Obstetrician and Gynecologists. This is very short CV of Dr. Jaideep Tang. It runs in pages, and I would like to put those 9 pages he had sent when he appealed for the nomination. And I'm very glad that our society has nominated Dr. Jaideep Tang for the elections for the president. And previously also Dr. Hemant Divakar, then Dr. Nandita Valshetkar, and he will be the 3rd who has visited, and even Dr. Patil Desai. They have visited Vijayapura OBGY Society. It is little, there are no flights, there is no airport. So it is truly reaching the unreached people. So I used to tell Dr. Sanjay Gupte in 2010 he had that this logo of means he had this. So you people have reached, and I think in your tenure we will definitely contribute much more. So welcome truly and wholeheartedly to Vijayapura OBGY Society, Dr. Dept.
Well, friends, we have lots of dignitaries along with us for today's inaugural function. We have our own Dr. S.R. Mukul sir, President Box Vijayapura, Dr. S.R. Bidri Madam, Professor Head of the Department OBGY BLDE University, Dr. Rashi Adiwal Madam, Secretary Box, Dr. Toby Madam, Professor of OBGY Alamin Medical College, and our beloved Dr. Arun Namdas sir, Professor Head of the Department of Dermatology for today's inaugural function. And I request all the dignitaries to inaugurate the session. Please, sir and madam. Virtual. Sorry, go. Start. Before we arrange for the inauguration function, I request Dr. Dept and sir, please say a few words with us.
Thank you very much. I will be sure to keep this very short because I am going to speak quite a lot later. And I don't want you to already become bored of me before I start my presentation. But let me thank the Vijayapura Society led by the President and Secretary, and thank Dr. Vidya Thobi for that very kind, warm and very generous, if I may say so, introduction. It is indeed my pleasure and privilege to be here. And Dr. Vidya, I don't think the journey to Vijayapura is as difficult as you made it sound. It was actually quite convenient to travel here, and I'm looking forward to visiting again if I'm invited again. Thank you very much, Dean Sir, also for making it for this function. And I'm looking forward to speaking with you and discussing the luteal phase defect as well as the recent amendments in the MTP Act with all of you. Thank you very much again for having me here. It's a real pleasure and privilege. Thank you.
I request all the dignitaries to inaugurate the session. Okay, please. It's indeed an honor to have Dr. Arun sir on this. We, as a student of sir, we know him as a great scholar, researcher. I request Arun sir to say a few words.
Good morning to all. Maybe accidental speaker. I thought at 11 o'clock there is a opening ceremony, inauguration rather, this CME, but I should be part of it. Well, all the members of the box, our departmental colleagues, and Dr. Jaideep Tang, who will be our candidate for the President Foxy also, from BLDE deemed to be university. I take this opportunity to welcome you, sir, and all the members of the board. It's a very interesting subject that is being discussed, the recurrent pregnancy loss. Well, very recently, I had an opportunity to see a female with SLE actually. I diagnosed it, and she was just 3 months pregnant. She told at the end while she was going out of my chamber, then I called back again, just to change my treatment. I should have asked, but somehow I saw the report, I was elated, okay, I had diagnosed SLE in a female, then I have to manage. But when she told very slowly that I'm 3 months, maybe she was interested to know what drugs I will prescribe. So she told 3 months, sir, should I take all this? Then I told you be here. Then I remembered this pregnancy loss and all. And then I told really what happened, I will tell you. I knew what else can be given, but still I told, wait for a while, I will call you back. Just again went through whatever literature is available in now it's very easy to go through internet. And then one thing which I was also thinking was there, that is add ecosprin also. So that is the thing which will cause the recurrent loss of pregnancy. And if you go through the various causes and lists, starting from genetic or the anatomical malformations which cause recurrent pregnancy loss, infections, autoimmune conditions. I know one of the topic is few of the topics which were in the first list, like genetics or antiphospholipid syndromes, which we also come across, especially the antiphospholipid syndrome, and then the treatable endocrine causes. And then with all this, I just went through the literature about recurrent pregnancy loss that time only, to how much I can help the patient. So it almost says, so it is so common also, but up to 64% of the time you can treat it. So that is a good news about the disease. Of course, you have to swim through all the causes and find out the best suitable answer. This experience made me to think, okay, any pregnant lady or woman with recurrent loss of pregnancy, we also take that history in antiphospholipid syndrome, which is one of the reasons for your recurrent pregnancy loss. And that lady, I prescribe, of course, chloroquine has to be, the hydroxychloroquine has to be there. And then one more drug which we can use in pregnancy is azathioprine and immunosuppression. No other immunosuppression can't be, you cannot use it. So, and then I added the echosprin. I was happy to see after 1 month, the disappearance of the lesions, especially with the first face and the very classic, the oral ulcerations, which are not painful actually. So anyway, I could have spared my slides. I didn't know that I will be talking to you. Then offhand, I have to tell this story. And also I told the attendants, as mother had come, actually, that is the usual practice. Mother will come accompany the doctor, pregnant lady. She was from some taluka place. I told her, please show this paper to your gynecologist or the obstetrician so that you have this disease. And every time you go there, please show this so that they also take care. And it is not one-man show. Interestingly, all these connective tissue disorders or the many causes which we are going to discuss in recurrent pregnancy loss, other than genetic or the anatomical causes, probably you need a multidisciplinary approach. So I have told them that you should take care and hope for the best. And what I have instructed, I have made a note in that to the obstetrician, after the delivery, please see the neonate also. One of the complications of the SLE in pregnancy is neonatal lupus erythematosus. A child may come with heart block. So that is the newborn may be born with heart block also. Or there will be telltale signs of the skin manifestations, also very classical ones. Anyway, if they are in our institution, I'd be more than happy to be assisting them. But unfortunately, they are from other places. So it also becomes every discipline people who are engaging with recurrent pregnancy loss system, whatever department we deal with, probably this mention and taking help, right, and timely help is very important. Well, I am not an expert in your subject, but whatever little, very recently I had that knowledge, so I thought I should share my ignorance so that I can improve more. I wish this CME will be definitely useful, very common topic, very interesting topic, very good speakers across Karnataka and also the experts also there. I bring greetings starting from Chancellor of our university, Vice Chancellor, Dean Faculty of Medicine, and all my colleagues for a wonderful scientific session. Thank you very much.
Thank you, sir, for sharing your experience. It means a lot to us. Now I request Sir President Box Vijayapura, to say a few words.
Good morning. I welcome you all for this CME program. I especially welcome Dr. Jaideep Tang, who is going to contest to the president post. Sir, from our society, college and city, we will assure you that we will all support you, and we want to see you as a Foxy president. Be assured, sir. So next, the two lectures are over, sir. We are all eager to listen to you regarding MTP amendments and Luteal phase defects. Thank you, sir.
Now, on behalf of the Box and BLDE University, we would like to have a ceremony where we would like to present State Dr. Jaideep Tang sir as a token of love and appreciation for, and all the paying has taken to come all over here and enlighten us regarding this interesting topic. I welcome sir the dais on behalf of the OBGY Society. Please, sir. I request all the dignitaries to join us and do the felicitation. Sir. Inaugural, sir. Madam, Vidri Madam, Tubi Madam, Jaju sir, Inaugural Madam, please join us. Jeshina, I request Dr. Nilama Patil Madam and Jyoti Kaur Madam also join us. Please, Madam. Madam, back. Come on, camera Sir. Performance.
Stop sharing.
Sharing not करो.
Just projector.
Any questions on this? Any other then I read his 9 pages. Because the answer, what she is saying,
Other pieces, ask them to come and sit. The thought is no, the pieces should come. ಅದಕ್ಕೆ ಜೂಮ್ ಮಾಡಿದಾಗ ಇನ್ನೂ ಶೇರ್ ಮಾಡೋಣ ಅವ್ರ ಲ್ಯಾಪ್ಟಾಪ್ಗೆ ಜೂಮ್ ಮಾಡಿ ಮಾಡ್ತೀವಿ ಅದು ಅಲ್ಲೇ ಶೇರ್ ಮಾಡ್ತಾರೆ ನಾನು ಡಿಸ್ಪ್ಲೇ ಆಗುತ್ತೆ ಔಟ್ ಆಫ್ ಥ್ಯಾಂಕ್ಸ್ ಅವ್ರು ಜೂಮ್ ಮಾಡೋಣ ಮೊದಲೇ ಹೋಸ್ಟ್ ಮಾಡಿ tally after the slides and you can see. No, just how to set up.
Recording in progress.
थोड़ा towards So we have reached the last part of this inaugural function. I'm sorry. Well, just a formal as a part of formality, we're doing the vote of thanks for today's inaugural function. For any function to start or run smoothly, we need a lot of guidance and support. As BLDE University has always stood for us, supported us and guided us. So I'd like to thank all the administrators and management who have supported us to conduct the CME. At first, I'd like to thank our Chief Patron, Dr. M.B. Patil sir, our beloved Vice Chancellor, Dr. R.S. Mudol sir, our dynamic Principal, Dr. Arvind Patil sir, Registrar J.J. Ambikar sir, Dean Faculty Allied Sciences, Dr. Arun Inaugural sir, and our Superintendent sir, Dr. Arish Murthy sir. Thank you, sir, for providing us all the facilities and support required for conducting not only this CME but also all the academics functions required in the past and in future also. I would like to mention the guidance and support given by our beloved Dr. S.R. Muddu sir, President BOX Vijayapura, our very own loving dynamic Dr. S.R. Bidri ma'am, Professor and HOD, Department of OBGY, BLDE University. Dr. Raj Shri, the most dynamic Secretary of BOX Vijayapura so far. Thank you, sir and madam, for entirely working and getting this CME success. I would like to thank the MQ Pharma, who's always stood for the cause of spreading the knowledge. Thank you, MQ Pharma, for getting this great speaker all the way from Mumbai to us and providing all the facilities and providing the very good feast here. I thank the Medical Education Department for providing the venue, the IT Department and Chirag for providing all the technical support for conducting this online CME in a smooth way. And then I thank all the faculties of Department of OBGY, the postgraduates, house surgeons who stood behind the scene, worked very hard to conduct this CME and made it a grand success. Thank you one and all. Now the academic session continues, scientific session continues. Hand over to Dr. Sushmita and Dr. Priyanka.
Thank you, sir. Now we shall move on to our next talk. I request Dr. Vijayapura ma'am, Professor, Department of Obstetrics and Gynecology at Al-Amin Medical College, Vijayapura, and Dr. Shailaja Imandan ma'am, Senior Consultant at Ishwara Hospital, Vijayapura, to chair the session. I also request Dr. Vijayapura ma'am to kindly introduce our beloved speaker, Dr. Jaideep Tang sir.
This is the camera, right?
So, thank you. Thank you, Vijayapura OBGY Society President Dr. Muddur as well as Dr. Rajeshri for inviting me as a chairperson for a very important talk. And for this, again, I invite and welcome Dr. Jaideep Tang. Just to highlight a few of the things about Dr. Jaideep Tang, is a past Secretary General of POXI. He has got many academic highlights and various positions he has held as a professional association at the international as well as national level. I just want to highlight some of his work at Foxy. So he has mainly done the upgradation of IT infrastructure of the Foxy office. And we all know how many of you have visited the Foxy website, I don't know. But he was the main person to do whole redo of those Foxy website. He has done updating of the code of conduct for the staff and other things. It is very interesting to know that our voting, what we do is e-voting, right? So there were many things, many objections for the postal votings. So he brought it into one line and he has started first time e-voting. And I just ask every one of you, please see that your membership, member number and how to vote. I think once we will do Zoom meeting, once the voting opens, then how to vote, I think our president and secretary should guide each and every person how to vote. Then we know amongst other documents, he was the lead author also for the Foxy statement for the preconceptional and prenatal diagnostic test act, cesarean section rates, medical termination of pregnancy guidelines. And also he has represented Foxy to the several meetings for the amendment of MTP Act. He is going to talk on this and framing the rules to the central government and various other stakeholders. Also, he has represented Foxy to the government of Maharashtra for the meeting of PCP, NDT and cesarean rates and other things. We all know the oxytocin issue, and during my committee, when I started my committee work, and this oxytocin issue propped up. And he has participated in the oxytocin issue to ensure that the oxytocin continues to be available in retail. He also ensured that the work at the Foxy office did not lag during COVID times. So that was very great. And we know various webinars that took place during even COVID times. So even he has participated in various activities in the FIGO leadership of obstetrics and gynecology. The principal investigator also at WHO, Foxy MVA pilot project also. So many things and so many publications, so many academics, and I'm sure that he is the right person to lead our Foxy. So I welcome again Dr. Jaideep for his wonderful talk again on luteal phase defect and in connection with recurrent pregnancy loss. Thank you.
Thank you. So, very good morning, leading into the afternoon to everybody. Let me first begin by thanking all of you for being there for this presentation. I must say it's a little different experience speaking on Zoom and a physical meeting at the same time. I don't know whether I should unmute myself or not before I start and ask whether my slides are seen and whether I'm audible or not, which is something we've all become so used to on Zoom. Let me begin by thanking the patrons of the college, and thank you, Dr. Arun Inamdar, for making time and being here. Thank you to the president of the Vijayapura Society, Dr. Mudanur and the secretary, Dr. Rajeshri. She has been in touch with me all the time, quite concerned about when I'm going to reach, etc. So, Dr. Rajeshri, thank you very much for coordinating my visit here, and of course, Dr. Bidri ma'am for facilitating this CME. Thank you, Dr. Jaju sir and Dr. Jayashri and Dr. Shobha and Dr. Bitri for the presentations before mine. And thank you, Dr. Vidya Thobi and Dr. Shailaja madam for chairing the session. I must specially congratulate Dr. Vidya Thobi both for the wonderful work that she did as committee chair, and it was such a pleasure to work with her because she was always so dynamic, so enthusiastic, and very, very systematic. In fact, I don't know whether I should say this, Dr. Vidya, but even during times of personal crisis, she made sure that she kept to her commitment and showed up for all the possible programs that she had organized. So thank you very much for all the work that you have done, and also many congratulations on your appointment as the president of a very prestigious organization, the Kasoga. I had the privilege of attending the last annual Kasoga conference, and I must say it was really such a vibrant and wonderful conference. Thank you also to the organizers, Dr. Sangamesh, Dr. Preeti, and Dr. Shridevi. I know the effort that goes on behind the scenes to make sure a CME of any size, goes off successfully. I'm going to speak on luteal phase in non-IVF and IVF cycles. And rather than concentrating on IVF cycles, what I'll try and do is elucidate the general principles of the luteal phase. But before I begin, let me ask and request all of you to please support me as I stand for the presidency of FOGSI. I don't know whether all of you have received that slip of paper which I had distributed. Have the PGs also got it? No? Okay. Sachin, can we give it to them, please? Have you got that paper? Okay. It's underneath the shawl and everything. Yeah. Can you give some here also, please? तुम्हाला मिळालं का? I speak to her a lot in Marathi. Yeah. So if you received it, I'll just ask you to take a look at it. It's got an adhesive on one side. So if you remove that adhesive, you can use it as a wristband. And the purpose of this is actually so that you would take a picture of yourself like this, or a selfie like this, and then post it on Facebook or WhatsApp to show that you are supporting me. But that's not all. There are some more things about this wristband. You'll see that there are 2 QR codes on it. Have you got one? Okay. Can Madam also have one, please? Can you have one? Yeah. So if you see, there are 2 QR codes on it. If you take your mobile phone and you scan those QR codes, the first one will take you to my website. And I'll talk about my website a little later. And the second QR code actually takes you to my Telegram channel, which you can join and where I put up whenever I'm speaking in a webinar, etc. But what's perhaps most interesting about the slip of paper is that the slip of paper is impregnated with basil seeds. So when you go home, don't throw this away. Put it in soil in your garden or put it in a planter. And if you water it every day for around 10 days, you will see that the slip of paper transforms itself into a plant. And when it does, can I request you to please take a picture of it and send it to me? Please take my number. I'll be putting it up a little later on the thing. And I'll be very happy to see plants growing out of this piece of paper if you get the time and if you have the inclination to do it. Let me begin this presentation by saying that perhaps luteal phase is one of those things that may not get the attention that it deserves. It remains like what Mark Twain said about a classic, something that everybody wants to have read, but nobody wants to read. These are the talking points of my presentation. We'll talk about why the luteal phase is important, a little bit about physiology. Then we'll talk about the luteal phase defect, and I will try and make a case for why it is important to provide uniform luteal support to all women who are undergoing treatment. And then we'll talk about the fact that luteal phase defect as a clinical entity actually seems to be irrelevant now. We'll then round it up with a discussion on which progesterone to use and why through a literature review, and then just a few words about the role of estradiol in the luteal phase. I understand that there are postgraduates here, and I must tell you, postgraduates, that when I started reading reproductive endocrinology after I joined MD, I never thought that all those physiology lectures, which I typically slept through, would be actually useful to me. And therefore, when I joined PG, I actually had to re-understand physiology. And I think it is very important to understand physiology. If you can get a hold of this book, there's a textbook which I used to read called Drogen-Muller's textbook. I did my internship in New York before I joined PG, and I discovered that textbook there. It's a really wonderful book, and it explains reproductive physiology in a way where I have never seen any other textbook explaining it so simply and in such basics. It's called Drogen-Muller. I don't know whether it's available anymore, but it's an excellent textbook to read for reproductive physiology. But let me begin by talking about why I said that the luteal phase doesn't get the attention it deserves. If you look at a typical infertility treatment cycle, you'll see that we pay a lot of attention to the follicular phase, right? We talk about oral ovulation induction, gonadotropins. In IVF, we talk about long agonist, short agonist, antagonist, and so on and so forth. But we seem to forget the fact that irrespective of what you do in the follicular phase, the luteal phase is the one constant in a menstrual cycle. And in fact, if you really think about it, the outcome of your treatment actually happens in the luteal phase. If the aim of your treatment is to ensure that the patient gets pregnant, the pregnancy doesn't take place in the follicular phase. The pregnancy takes place in the luteal phase. And yet, if you go through any program, any conference program, you will see that typically around 70% of the program is devoted to the follicular phase. Around maybe 15-20% is devoted to diagnosis and investigations. And luteal phase is typically pushed in one corner. It's given either one lecture somewhere or one panel discussion, and nobody talks about it. So that's quite unfortunate because, as I said, it is the one constant of any treatment cycle that you do. And the implications of the physiology of the luteal phase are actually very important. So if you understand the physiology of the luteal phase, you will easily understand that whenever you either use a trigger or you perform any kind of manipulation on the growth of the oocytes via ovulation induction or ovarian stimulation, you are fundamentally altering the luteal phase. Let's dig a little deeper into that and try and understand what I mean by that. Again, going back to a little physiology, because I found that as we grow more senior, we tend to forget these basics. But if you remember these basics, then it's very easy to understand everything in infertility, starting from oral ovulation induction to IVF. We know that there's a follicular phase. And if you follow the two-cell theory of metabolism within the oocyte, you know that in the follicular phase, you have granulosa cells, which produce estrogen. Through positive and negative feedbacks of estrogen and a small spike of progesterone, which occurs just before ovulation, the LH surge takes place. After the LH surge takes place, the metabolism within the oocyte shifts from granulosa and estrogen to theca cells, which produce progesterone. Am I clear or am I being confusing? Because I found that whenever people who do IVF speak about infertility, we always tend to confuse people. Long protocol, short protocol, ultra short protocol, antagonist protocol. always used to wonder why we do it, and then I realized we do it so that people think it's very complicated. Don't do IVF and more patients come to us. So I hope I'm not being confusing. I hope it's very clear. Follicular phase, granulosa cells with estrogen, LH surge, ovulation, followed by a transfer of metabolism from granulosa to theca and progesterone. Quite all right, right? Now, what happens when you give a trigger? For that, you have to understand the structure of the HCG molecule. The HCG molecule has two subunits. There is an alpha subunit and there's a beta subunit. It's the alpha subunit, which is a biomimic of LH, and in essence fools the oocyte into thinking that the LH surge has taken place. The big difference between the LH surge that takes place with an injection of HCG and an endogenous LH surge is that the endogenous LH surge is titrated via those feedback mechanisms that I talked about, so that the amount of LH that is produced is optimized for the level of estrogen and progesterone. But when you give an injection of HCG, it's a fixed dose of the biomimic LH that you are giving. And because of that, what happens is that the shift of metabolism, which has to occur from granulosa and estrogen to theca and progesterone, gets compromised. And because that gets compromised, it produces what I like to call the iatrogenic luteal phase defect. Now, if you have understood this, the next question that you would like to ask is, can we diagnose which patient will have the luteal phase defect so that that patient can be given luteal support, the other patients don't need it? Unfortunately not, because even now, there is no uniform definition of the luteal phase defect that has been agreed upon in literature. And moreover, look at the way we diagnose luteal phase defect. We typically diagnose it on day 21 by doing a serum progesterone, or we take endometrial biopsies between day 20 and 26 and correlate that with the noise histopathological criteria for endometrial dating. The big problem with both these is that you make the diagnosis post facto. By post facto, I mean by the time you make the diagnosis, it's already too late to influence implantation in any way whatsoever, because implantation has already occurred around the periovulatory period. So you can't make a diagnosis around the periovulatory period, your diagnosis is post facto, which then raises a further question. Can't we make a diagnosis of luteal phase defect in this cycle and then extrapolate the findings of that cycle to the index or the treatment cycle? Well, the answer unfortunately is no, because if you really think about it, every cycle is different. Every cycle has a new oocyte, new levels of estrogen, new superficial layer of endometrium, and new levels of progesterone. So how can you extrapolate the findings of one cycle to the treatment cycle? You can't. Which is why a whole lot of literature seems to suggest that don't bother making a diagnosis of luteal phase defect. One, because you can't make it in time, and two, because you cannot extrapolate the findings of one cycle to the next. In fact, the American Society of Reproductive Medicine has gone so far as to say that the luteal phase deficiency as a clinical syndrome is irrelevant in current times. So don't make a diagnosis. Whenever you do a treatment, either ovarian induction or ovarian stimulation, or use a trigger, provide uniform luteal support. And that, in fact, is what is done almost all over the world. All specialists who practice infertility and all generalists who practice infertility tend to provide uniform luteal support to all their patients. So, to conclude this section of the presentation, although it seems to be very promising in terms of the biomolecular effects, etc., most of the factors actually cannot be evaluated and therefore provide uniform luteal support to patients who are undergoing treatment. Now, if you're going to provide uniform luteal support, then that means you're going to give luteal support to a whole lot of patients, in which case you must understand what your options are. We used to use HCG earlier, but no longer. The reason we don't use HCG anymore is, first of all, the results with HCG are no better than the results with progesterone. Secondly, HCG is the only thing that stands between you and ovarian hyperstimulation. By that I mean, if you don't give HCG, the patient won't get hyperstimulated. That's simple. Particularly in the beginning, when you start follicular monitoring, you sometimes get a little worried when you see 7, 8, or even 10 follicles. Don't worry. Stop the cycle. Don't give HCG. Very importantly, tell the patient to not keep relations. Tell her to abstain. Otherwise, even she may have a spontaneous LH surge and land up having a high order multiple pregnancy. But if you don't give her HCG, she won't get hyperstimulated. It's as simple as that. You are therefore left only with progesterone. And when you are talking about progesterone, it's available in 3 forms: oral, IM, and vaginal. If you are talking about the oral form of progesterone, and I think this is extremely important, particularly at the beginning of your career, do not use natural micronized progesterone orally. Because there are several studies, including that one by Bourgain and by my teacher, Professor Paul Devroy, who reported absence of any secretory transformation if you give natural micronized progesterone orally. So giving natural micronized progesterone orally is a complete waste of time, resource, and medicine. If you want to use something orally, then in fact, in the modern day and age, your only option is dydrogesterone. Dydrogesterone, contrary to popular belief, has actually been around for a very long time. If you look at that first study from Whitehead, you'll see that that study is from 1980. And there is also an Indian study from 2005 by Dr. B.N. Chakravarti sir from Calcutta. And he was actually one of the first people to propose that dydrogesterone as a stand-alone medicine is good enough for luteal support, even in IVF cycles. So dydrogesterone has been around for a long time. You can look at all those references there which talk about dydrogesterone. And yet dydrogesterone has always had this bit of a shadow of scientific illegitimacy. Perhaps because there were no robust, well-designed trials to talk about its efficacy. It also did not help when there was a scare for connecting dydrogesterone with congenital anomalies. And particularly for the PGs, again, look at that second study. It showed that there was a correlation. And the reason I'm showing you that second study is that you have to look at the broader context in how a study is reported. That second study was reported from a war zone, where bioweapons, chemical weapons, and so many other things were going on. And I think it would be fair to conclude that perhaps those were responsible for that slightly higher incidence of congenital anomaly rather than dydrogesterone. It is now quite well proven over millions of births that dydrogesterone has no association with congenital anomalies. And yet there was still a bit of a paucity in literature. People were using dydrogesterone quite happily, but there was always this at the back of the mind that perhaps we are not being scientifically as robust as we should. And therefore, before I move on to the next 2 trials, let me talk a little bit about non-inferiority trials, because the next 2 trials that I'm going to talk about are both non-inferiority. Non-inferiority trials are suddenly very much in fashion nowadays. There is the Champion trial, which talked about carbetocin and oxytocin. There are the Lotus 1, Lotus 2 trials, and so on. Why are non-inferiority trials popular? Well, there are a whole lot of deep reasons, and I hesitate to talk more about it in a medical college where there are so many people who do studies all the time. However, very briefly, it's all about sample size. And the fact that for something where a gold standard exists for treatment, you can't do intervention versus no intervention trials. So I'll give you the example of carbetocin and oxytocin. You cannot do a trial where you compare carbetocin versus no intervention. That would be ethically wrong, because you know that the addition of a utrotonic reduces PPH and saves patients' lives. You therefore have to compare carbetocin against something, and what you compare it against is the gold standard of practice in the current day and age. Similarly, you cannot do a trial of dydrogesterone versus no intervention. Because now, as I have shown you, luteal support is important to get good pregnancy rates. Therefore, you do non-inferiority trials. Because if you want to prove superiority between two interventions, the sample size that would be required would be very, very large. So non-inferiority trials typically have a little smaller sample size, and they have what is known as a non-inferiority margin. The point I'm trying to make here is that if the 95% confidence interval is entirely above zero for all data points, you in fact establish superiority at a 5% level of significance. So for the last couple of minutes, what I've been going on about is actually for this trial. This trial was a very nice, very elegant and fairly robust trial called the Lotus-1 trial, which compared 10 milligram TDS of dydrogesterone versus 200 milligram TDS of natural micronized progesterone given vaginally. Do you have a pointer? And if you look at the outcome of the trial, you could see that over there, this line, that is the margin of non-inferiority. And see where all the data points are. They are somewhere around 5%. And as I already showed you, that indirectly, this actually demonstrates superiority. Similarly, when you look at the Lotus-2 trial, which compared 10 milligram of dydrogesterone TDS versus the use of natural micronized progesterone gel. The first one was with capsules, the second one is with gel. Again, look at the non-inferiority margin and look at all the data points considerably away from the 0 point, which, as I said, also conclusively proves superiority. So the authors of the trials were actually surprised at these findings because they did not think that it would establish non-inferiority with these kind of confidence intervals. So they looked back at their data. They went back to individualized patient data, IPD they called it. And when they did that and pooled the IPD of both the trials together, they had an adequate sample size to actually prove superiority, which has led to papers like this, which say that oral dydrogesterone is perhaps the new standard for luteal phase support. There is, of course, intramuscular progesterone. And I must say that I have not used intramuscular progesterone since around 2001, 2002. I started doing IVF in 1999. And I started with intramuscular progesterone because at that time, it was the only form of progesterone which was legally available in the country. Vaginal progesterone was available, but it was available in the grey market, so I never used it. However, IM progesterone is extremely painful to the patients. You know, sometimes I like to joke that we all have these patients. They keep on coming back to us, but they're not getting pregnant. And then at some point in time, you want to tell the patients, Baba, I can't do anything for you. Please go somewhere else. But of course, you can't tell the patient that. Just give her 2 injections of iron progesterone. Rest assured, she's going to go to the next door clinic. Of course, there are other ways of giving systemic progesterone. However, I really don't understand why you would want to use these routes of administration, given the fact that dydrogesterone is effective, vaginal progesterone is available in all these varieties and formats, and the fact remains that serum levels of progesterone don't really correlate with clinical outcomes. So if you look at that data, this purplish pinkish thing is the serum level of iron progesterone, which is obviously much higher than the yellow levels over here of vaginal progesterone. However, clinical outcomes are absolutely the same. So don't use serum progesterone as a marker for how good your luteal phase support is. Lastly, about estradiol for luteal phase support, well, the jury is still out on it. I unequivocally told you that use progesterone for uniformly providing luteal support to all cycles. The same is not true of estradiol. In clinical practice, I use estradiol for luteal support when I find that in the previous cycle, despite giving progesterone, that patient's luteal phase was short. So around 10, 12 days instead of the expected 14 or 16 days. Then in the next cycle, I give them estradiol along with progesterone. An important question to ask is what is the best time to start luteal support? Well, it's very easy in IVF. You do the pickup and a couple of hours later, you start the luteal support. not so easy when you're talking about oral ovulation induction or IUI. So you need to extrapolate. And when you extrapolate, you realize that after the pickup means around 38 hours after giving the HCG is when you start luteal support in IVF. Extrapolated to an IUI cycle or a oral ovulation induction clomiphene letrose cycle, and you realize that you need to start luteal support for these patients around 42 to 48 hours after giving the trigger. So we typically consult in the evenings. If we've given a trigger at 5 p.m. on Friday, then I'll start luteal support somewhere around 5 p.m. on Sunday. When do you stop luteal support? Well, there are many brave souls who think it's good enough to stop luteal support even up to 30 days of embryo transfer. That means practically as soon as the patient gets pregnant or until fetal heart activity is seen. But to tell you the truth, as anybody who does infertility will tell you, you're so happy to get a pregnancy that we typically don't stop it until 12th week of gestation and sometimes even go beyond. So in summary, you should use luteal support wherever you use gonadotropins and oral ovulation induction and or a trigger with multiple follicle recruitment. IM and vaginal are equivalent, but don't use IM. Dydrogesterone is at least as effective and as I showed is actually superior in fresh IVF cycles compared to vaginal progesterone, and the duration of luteal support required may be shorter than current practice. So let me end with this slide and this picture on this side over here. I don't know how many of you know the story of this picture, but this is a baby born to a lesbian couple in the UK. And as they have written on their Facebook post, it took 4 years, 7 attempts, 3 miscarriages, and 1,616 injections. After the baby was born, they wrapped the baby in this pride blanket, and they had saved all those 1,616 syringes and needles, which they arranged in the shape of a heart around the baby. And as you will realize, it is a very touching picture because it speaks about the efforts which our patients take to get pregnant, and therefore behoves us to do the very best that we can for all of them. Let me again end by requesting support from all of you. I told you I'll tell you about my website. I believe this is the first time anyone in Foxy has set up a website for an election. The PGs may not know, but the Foxy, what we have been constantly referring to, is the Federation of Obstetrics and Gynecological Societies of India. We have around 34 to 38,000 members. It varies every year. And we have around 267 constituent societies. It's a fairly important organization. I believe it is one of the largest. I believe it's one of the largest association of professionals of gynecologists anywhere in the world. And it's an old organization. The 75th anniversary of the organization is coming up soon. And I was fortunate enough to be in the managing committee of Foxy since around 2004. I've been working actively in Foxy since 2000, so that's 21 years now. But I've been in the managing committee since 2004, and for the last 9 years, I've been an office bearer of Foxy. So that's Foxy. In case you are not members, you become members. You can become members by joining your society. There's no direct membership. Join the local society as an annual member. And if you are from outside Vijayapura, when you leave Vijayapura, you can get your membership transferred or leave this membership and join that society. You want to say something?
All the postgraduates of this institute, plus Alameen Medical College, plus the DMD students in district hospital,
all are members. That's really nice to them. So that's my website. Once you go there, you can register your support for me, and I'm quite happy to share that literally thousands of Foxians have already registered their support for me. There's a video blog section in the website. And, you know, I speak quite a lot. My wife doesn't think so, but I think I talk quite a lot. And I've spoken in around 850 odd webinars since the lockdown began. I've convened several series, the O2S series, the G2I series, the Bara on Bara series, and a whole lot of those videos are there on this video section. And you could also join a Telegram channel, you know, to follow whenever I speak in webinars, etc. So thank you very much for a very patient hearing, and it's really a pleasure and privilege to be here. Thank you.
Thank you for your wonderful and informative speech, sir. Any question from our institute? There are not many postgraduates here in the audience. Any infertility questions? Any questions? As he has done 850 webinars, and I think any questions are welcome.
Sir, I can do my second presentation and
Yeah.
you can take questions.
Want to do the second talk, sir?
Should I finish it? And then we can do all the questions. Right. So I'm next going to speak on MTP Act and update. And let me begin with a thought. I don't know how many of you are aware, but obstetricians and gynecologists, those interns have gone, no? Otherwise they'll get scared and not take obstetrics and gynecology. You're there? Okay. But don't get scared. We are quite all right. Okay. Obstetrics and gynecology is actually the most regulated specialty in medicine. The number of laws and policies and rules that we have to follow outnumber even the laws and policies that transplant surgeons have to follow. So obviously the government thinks that obstetrics and gynecology is more difficult than doing a cardiac, a renal, or even a liver transplant. And this has led to a certain cynicism or skepticism, if I may say, about the law, the courts, judges, lawyers in general. This kind of cynicism and skepticism is very nicely reflected in this quote. I don't know how many of you are Harry Potter fans, but I love those books. And I thought the Deathly Hallows was one of the finest ones. And in that, Scrimgeour asked Hermione, "Are you planning to follow a career in magical law?" And Hermione says, "No, I'm not. I'm actually hoping to do some good in the world." And that is the attitude that we as service providers have towards law, lawyers, courts, judges, etc. General cynicism and skepticism. And because of that, I feel we don't pay enough attention to the laws and policies which govern us. Now, I'm not going to ask for a show of hands, but just think for yourself, how many of us have actually read the MTP Act from cover to cover? But if you've not read it, I'm glad, but if you've not read it, I can tell you that you're missing out on what is perhaps the most elegant piece of legislature which has come out of the Indian Parliament. It's elegant because it's short, it's simple, and it's very comprehensive. All that it does is tell you who can do the abortion, who can undergo the abortion, and where can the abortion be provided. It just answers three simple questions. However, to understand the importance of the amendments and the context of the amendments, you need to look at the timeline and how the MTP Act came into being. And the story actually starts in 1860. When the Britishers were ruling over us, they promulgated the Indian Penal Code. And these sections of the Indian Penal Code criminalized abortion in our country. When I say criminalized, what I mean is that both the person who provided the abortion as well as the woman who underwent the abortion were both deemed to be criminals under the Indian Penal Code. So because abortion became criminal, it was driven underground. And because it was driven underground, the morbidity and mortality from abortion started to rise. The government realized this and in 1964 asked Mr. Shantilal Shah, who was a retired bureaucrat from Mumbai, to set up a committee and look at ways to reduce mortality and morbidity from abortions. The committee worked for 2 years and produced a report which is now known as the Shantilal Shah Committee Report and presented it to the government. This paper that you see here, this is from the original Shantilal Shah Committee Report of 1966. I got it from the Library of Parliament when I had gone to make a presentation to some parliamentarians about the MTP Act. So the government took up the report and finally the law got passed in 71 and then got implemented in 1972. But if you want to understand how MTPs or abortions are provided in this country, it's not enough only to know the Act. Because the Act just provides an overview of safe abortion and then delegates authority to central and state governments. The central government gets to make the rules. They frame the rules, they get it ratified by Parliament, and these rules are then applicable all over the country. And in fact, as I will illustrate a little later, these rules can sometimes have a bigger impact on our practice than the Act itself. The state gets to make regulations. These regulations are typically framed by the center, and then the state gets to adopt these regulations or modify the regulations. This is because in India, health is a state subject. So whenever you make any policy or act or law on health, the state also needs to have a say. So the state gets to make regulations. They involve opinions, reporting, and maintaining secrecy. It will interest you, however, to know that in both the amendment rounds, 71, 72 and 2002-3, not a single state has changed even one word of the regulations which have been promulgated by the center. They have just said, these are the regulations, we adopt them, and now everybody follows the same regulations in our country. And then you also need to look at SOPs, that is standard operating procedures. So how we provide abortion in this country stems from the Act, the rules, the regulations and SOPs, all taken together govern how we provide abortions. This is a good example of how sometimes the rules can have a bigger impact on practice than the Act itself. This what is highlighted, this one line, which is highlighted here in blue, which is actually an explanation to one of the clauses in the rules of the MTP Act, is why we have mifepristone and misoprostol in this country. Can you imagine? One line now accounts for the legality of 80% of abortions in our country, because 80% of abortions in our country are now provided with mifepristone and misoprostol. So as I said, a large impact on practice. And then of course, you need to look at SOPs or guidelines which the central government brings about. And we continue to use mifepristone and misoprostol in the second trimester because the comprehensive abortion care guidelines from the government of India say that that is the safest way to provide abortion in the second trimester. It also helps when associations of professionals like FOXY come out with guidelines, and that is the FOXY and ICOG, which is the Indian College of Obstetrics and Gynecology, Good Clinical Practice Recommendations, GCPRs on MTP. And I had the good fortune of drafting these. When I was the chair of the MTP committee, I had drafted this in 2004, when I had just taken over as the chair. And I'm quite happy to understand that there's no need for redrafting these because they were quite forward thinking. But sometimes lawmakers sitting in their own silos make laws which have unintended consequences and affect good laws like the MTP law. And a good example of that is the PCPNDT Act. Because of the way the PCPNDT Act is both drafted as well as implemented, it has become an impediment to abortion. I always have this argument with my radiology colleague. Okay, I'm standing for election, so not argument, healthy discussion with radiologists. When they say crack down on sex-selected abortion and you'll normalize the gender ratio. And I said, you don't realize how wrong you are. Because when you crack down on one form of abortion, you crack down on all forms of abortion. And it's a well-documented fact that 90% of women who seek abortion in second trimester do so because they genuinely need it. 10% and maybe lesser seek abortion for sex selection. And I always tell the radiologist that if you crack down on those 10%, you are going to affect those 90% of women who actually need the abortion genuinely. Moreover, the problem should not be the sex-selected abortion. If there was no gender determination, so go upstream, and if there was no gender determination, there would not be any sex-related abortion, which is what the PCPNDT Act is actually meant for. And then there is, of course, the POXO Act. The POXO Act is the Protection of Children Against Sexual Offences Act. A well-meaning act, an act which is needed in this country. But unfortunately, the people who drafted this act took what we call a very Mai Baap Sarkar kind of an approach. What they essentially said was that adolescents are too dumb and immature to understand sexuality and cannot take care of their own bodies and sex. So let's ban all sexual activity below the age of 18. In fact, what the act does is it conflates child sexual abuse with adolescent sexuality, which is obviously a problem because the act essentially makes all adolescent sexual activity, and here adolescents defined as less than 18 years of age, criminal. So any adolescent who indulges in any form of sexual activity, any form including petting, kissing, so on and so forth, is a criminal in this country. And it's very strange because on the same government website which has this horrific looking POXO document, there is also this wonderful RKSK document which says, of course, adolescent sexuality exists. Of course, adolescents must be informed of this and contraception has to be made available to adolescents. So obviously this has led to a lot of conflict and conflation, and these are some of the common questions I get asked about the POXO Act. Do you have a legal duty to inform the authority if a minor girl is pregnant? The answer is unequivocally yes. Even if the girl has not expressed a desire to take action, even if the girl is a married minor, and remember minor here means below 18 years of age, and even if the girl's age is uncertain, you have to inform the authorities. Unless there are child special services in your locality, typically the authority is the police. How will you inform? On your letterhead, write a note saying that Miss So-and-so, age about so-and-so, has come to see me and I find that she's so many weeks pregnant. Take 2 copies to the authority, give them 1 copy, take a received stamp on the other and come back to your clinic. Once you have informed the authorities, your duty as a provider under the POXO Act is complete. And you and the girl now move back from the POXO Act into the MTP Act. In fact, the MTP Act is extremely generous with adolescents. All that the MTP Act says is that to procure an abortion, anybody below the age of 18 has to be accompanied by a guardian. Now see the importance of words. The MTP Act says guardian and not legal guardian. So for the purposes of an MTP Act, the girl could be accompanied by anybody above the age of 18 of sound mental mind. It could be elder sister, elder brother, boyfriend above age 18 and so on. So once you have informed the authorities and you have come back to your clinic, you can now provide the abortion without waiting for any further medical legal procedure. Unless and until the authority explicitly in writing has told you don't do that abortion. This is another controversial topic. Do you have to preserve products of conception for abortions in these girls? Because technically, this is statutory rape, and the pregnancy could be construed to mean evidence of rape. So a lot of judges and lawyers are given various opinions on it, but we had a consensus meeting with some Supreme Court judges and eminent lawyers and the Jindal University and ICAS, and the consensus that emerged was you do not have to preserve products of conception unless and until the authority explicitly in writing has told you to preserve the products. So this is the last time the amendments took place, 2000 to 2003. And I'm quite fortunate because I was a part of this process and I was a part of this new amendment process also. So that's a screenshot of my calendar. And the reason I'm showing this to you is because of what happened on that day. 6th October 2008, MPP amendments meeting at the Ministry of Health and Family Welfare, New Delhi. 2008. That was one of the first time I attended an official meeting for the amendments, and there were several other stakeholder meetings before this, and this is how long it has taken for these amendments to happen. They've just got passed in 2021. In fact, a lot of advocacy has gone into it. These are a lot of articles I have written. I've written in mainstream media, Hindustan Times, Mumbai Mirror. That's my editorial 1 and 2 in the Hindu, and there are many others. I've actually been quoted in law journals. I've even published in law journals. This is part of an interview which they took my interview and then they published it in the Jindal Law Journal. And I've also published in International Journal of ONG. And as I said, I've also made presentations to parliamentarians on the need for the amendments. And the point that we had made at that time was that the question of abortion should not be an issue in the political arena. When a woman or a girl has to make this kind of decision, she should be able to see her doctor, not her lawyer, which is what was happening till then. We also visited the Prime Minister's office. We didn't meet the Prime Minister, but we met the person in charge of health at the Prime Minister's office. You can see that's me, Dr. Jaideep Malhotra, and Dr. C.N. Purandare standing outside the PMO. And we conveyed to them that these are all the changes that are urgently needed to rationalize the MTP Act and make abortion more available to women. And we were really delighted, therefore, that when this act was presented in the Lok Sabha and Rajya Sabha, they had taken notice of all of our requests, except the first one. We'd also requested that abortion should be a woman's right till 12 weeks, but they said no for that. But everything else was accepted. And in fact, in the Rajya Sabha debates, that's Dr. Harshvardhan, who was, I won't put the volume on because there'll be echo, but when he was speaking in the Rajya Sabha, for the first time ever, I believe, he mentioned Foxy as the first stakeholder who was consulted before the MTP Act was amended. So that was quite a happy moment for Foxy. So these are the amendments, and let me take you through them. The amendments first say that there should be a medical board which should be formed, and we'll talk about that a little later. For the first time ever, the Act now says that you can provide an abortion either medically or surgically. So for the first time ever, the MTP Act mentions the methods of providing an abortion. I believe this is a bit of an underrated change. I think it's an important change because this should ideally take care of all the controversies around meso in the second trimester, off-label, illegal, and so on. A quite important change. Till now, we had to take one opinion for terminating pregnancies up to 12 weeks and two opinions between 12 and 20 weeks. That has now changed. Now you need only one opinion, right up to 20 weeks of gestation, and two opinions for terminating a pregnancy between 20 and 24 weeks. Another change, which appears to be minor, but in fact has fairly large societal repercussions, is removal of the word married in that failure of contraception clause. If the PGs don't know, there is a clause in the MTP Act which says failure of contraception and an unintended pregnancy because of that constitutes grave mental injury to the woman's health and therefore is an indication for terminating the pregnancy. The problem with that clause was that it had the word married woman in it. So unmarried women could not access abortion using this clause. It seems to be a small change, but the government has removed that word married. And why do I say it is a change which has societal implications? I say it because now the government has accepted that even unmarried women have sex, even unmarried women can have an unplanned pregnancy, and even unmarried women need access to safe abortion. And that's why I said societally it's quite an important change. Within the Act itself, the gestational age limit has been extended to 24 weeks of gestation. Now, the next two changes that I'm going to show you are indeed quite breathtaking. They actually make India's abortion law amongst the best in the world. See who can undergo an abortion in India up to 24 weeks. And look at that list. Survivors of assault, minors, change of marital status, women with physical disabilities, mentally ill women, fetal malformations, and even women with pregnancy in humanitarian or disaster settings. If you think about the indications of MTP that are available in the MTP Act, in fact, The only thing missing from this list is failure of contraception. So we now become one of those very rare countries in the world where we are allowed to do MPPs up to 24 weeks of gestation for all indications except failure of contraception. Failure of contraception still remains till 20 weeks. Moreover, you can perform abortions up to 24 weeks if you are a degree or diploma holder in obstetrics and gynecology. You are qualified to perform abortions right through the gestational age, 40 weeks. No need for any fresh training or certification. And if your facility, some of you are from private clinics, if your facility is registered up to 20 weeks, then there is no fresh registration, reapplication, certification, or even inspection of premises which is required to provide abortions up to 24 weeks. Another extraordinary change. For patients who need an abortion after 24 weeks of pregnancy, for fetal malformations, you can now go to a medical board and see how simple they have made the medical board. The gynecologist, pediatrician, or radiologist, and you can add or remove people as you would like, depending on the gazette from the state government or union territory. Now, this is where there's been a bit of a lag between policy and implementation. The Act has been notified way back in October. However, medical boards have still not been formed. So I had this phone call around a month back from a couple in Delhi saying that we are 28 weeks pregnant. Our fetus has got very severe complex congenital cardiac anomalies and we want an MPP. I said, well, that's fine. Go to the medical board and take permission and get the MPP. They said, oh, but there's no MPP board in Delhi. So then I helped them draft an affidavit and I told them, go to the High Court, but don't ask them permission for the abortion. That is no longer within the court's ambit. Simply ask the High Court to form a medical board. Because formation of medical board is now the law of the land, the High Court gave an order the very same day in the first hearing, and the medical board was formed in AIIMS, New Delhi. They went to the medical board and she just got the abortion around 2 weeks back. And this is such a remarkable change. You know, till now, the procedure was for any pregnancy beyond 20 weeks which needed an abortion, the patient had to go first to High Court. The High Court would take 1 or 2 hearings and then ask a medical board to be constituted. The medical board could take its own sweet time and decide when to give an opinion. Sometimes it took 2 weeks, 3 weeks. Then in a sealed envelope, the medical board had to give the opinion to the High Court, where the judge would decide whether an abortion is required or not. Obviously, this took time. You know, I was asked to consult on a case in Supreme Court once, 2-3 years back, where there was this 12-year-old girl. Now imagine this, 12-year-old girl in a small village somewhere in our country. Parents are daily wage earners. They have to go to the fields every day, mother and father, to make a living. So they leave this 12-year-old girl with the maternal uncle, not of course understanding that the maternal uncle was the worst kind of predator, a pedophile. The uncle, who's around 70 years of age, repeatedly rapes this 12-year-old girl. Repeatedly, till inevitably she gets pregnant. Now, not having had the benefit of menstrual hygiene education, sex education, this poor 12-year-old girl doesn't realize she's pregnant. And by the time her mother realizes that my daughter has not got periods since a long time and takes her to the doctor, that 12-year-old is already 22 weeks pregnant. Obviously, at the local health center, she's told, we are sorry, in India, abortions allowed only up to 20 weeks. You're 22 weeks, and so we can't do the abortion. So then they start making the rounds of authorities, courts, medical boards, and just imagine the trauma the girl and her parents are going through. Every time they go before a new doctor, before a new authority, before a new court, before a new judge, they have to keep on reliving the trauma because they are kept on asking, how did it happen? What happened? So on and so forth. Until finally, this 12-year-old and her parents reached Supreme Court, which is when I was asked for an opinion. But you know, by the time she reached Supreme Court, she was 32 weeks pregnant. It took 10 weeks for her to reach Supreme Court. And the Supreme Court, in its wisdom at that time, said, well, you are healthy, the fetus has no anomaly, so we are not going to give you permission for an abortion. This 12-year-old then had to go back to her village, take the pregnancy up to 37 weeks, and underwent a cesarean section to give birth. Imagine if this law would have been there, this would never have happened. This girl and so many like hers would never have suffered. And that's why this change or this rule for the medical board is even more remarkable. It says that when a medical board receives a request for a termination, it has to give an opinion in 3 working days. So no need for court. You can go to the medical board directly and you have to get an opinion in 3 days. And if the medical board agrees that this abortion is needed, then the medical board has to ensure that the abortion is provided in 5 working days. Now imagine what a dramatic change this is. What used to take weeks, months, going to various authorities will now be solved by going to one authority within 5 working days. It's really quite remarkable. Section 5A1 has caused some consternation because it talks about penal provisions for breaking confidentiality. But remember, I told you regulations which talk about maintaining secrecy come under regulations, and the draft regulations have not yet been formed. So we are waiting for them to be formed, and hopefully we will get some clarity on this. There are some changes in training requirements which reflected in opinions, and there are 2 forms. There's one form which the medical board has to fill, and this is the form we have to fill in case we provide an abortion between 20 and 24 weeks. We are, of course, also waiting for the SOPs, and these are the SOPs I had drafted for the government of Maharashtra. That's the letter requesting me to be the principal author for the government of Maharashtra's guidelines for abortions beyond 20 weeks. I believe this has been sent to the center, and hopefully the center will take cognizance of this. In fact, after the amendments came out, I was asked by the government of India to write an editorial on the amendments. And I was quite pleasantly surprised and very happy when the government of India released my editorial as an official press note to all the high commissions and embassies of India all over the world. If you go to a whole lot of embassies and high commission websites, you'll be able to see and read my editorial. But there has been some criticism about the amendments, saying that perhaps the amendments didn't go far enough. We could have done more. But I respectfully disagree. I've just completed my tenure of 3 years as the Global FIGO Committee for Safe Abortion Chair. And that's given me a bit of a global context on abortion laws. I don't know how many of you know, but in the USA, supposedly the most advanced country in the world, there are entire states, not cities or districts, entire states where there's not a single abortion provider available. Can you imagine? In fact, Texas, the largest state in America, restricts abortions to 6 weeks. It's quite unfathomable how they have passed that law. And it's resulted in this quite funny situation where American citizens from Texas are now going to Mexico to get abortion-related health care. And in fact, we are quite lucky to be living in a country with such great abortion laws. Of course, the path from policy to implementation is never straight. In fact, it is fairly tortuous. But we have to navigate this path. Because almost all abortion-related deaths are preventable. And in fact, when abortion is performed by qualified people using correct techniques and sanitary conditions, it is one of the safest medical procedures. Forget medical abortion. But just think back, PGs are here, everybody is here. If you remember your residency days, you're fresh out of MBBS, there's hardly any surgical experience. And one of the first procedures we are given in training is either a gynec DNC or a surgical abortion. Now, it's such a safe procedure that our teachers feel confident enough for us to do it with no surgical experience under supervision. And for want of such a safe procedure, women are dying. They're not dying only in India, they're dying all over the world. We must stop unsafe abortion. After all, history is her story too. Thank you very much.
Thank you, Dr. Jaideep, for those two wonderful lucid talks and your vast experience in that those FTP amendments and everything is really worth sharing with us. I congratulate you for that.
Thank you.
And really this expansion is going to help us. And recently we had RSC training to Foxy
Yes.
in our society. So all those, even the records and everything.
Yeah.
So if it is any questions, any queries, Dr. Jaideep would like to answer. Who wants to ask?
Yes.
Sir, I have got two questions.
Yes.
Number one, the medical board, state medical board is not mentioned.
Yeah.
What about calculation, and
Yes, sir. So
places where it can be.
Yeah. So when I was in the committee about the rules where we discussed this, the aim is actually that every district should have its own medical board. That is the aim. What I said about state boards was that the state has to issue a gazette establishing the boards. So it's not a state board, the state only issues a gazette. And this is the lag because after the act has been amended, there are hardly any states which have issued a gazette. Only that one in Delhi, which also happened because that patient went to court. So I think this is an urgent advocacy need that we should advocate with our state governments that you urgently need to come out with a gazette which establishes medical boards because everything else about the medical boards already in place. So there are two ways, sir, of getting this done. One is, of course, that we advocate with the state and so on and so forth. The second way is what happened in Delhi, that if a patient comes who needs an abortion after 24 weeks, we advise the patient and tell her that don't go to court seeking an abortion because that's no longer the High Court's remit. Go to court seeking a medical board to be set up. So two ways are there, advocacy or going to court. It's better always to try and get it done by advocacy. But if nothing works, then I work with an organization called Human Rights Law Network. So we have done quite a lot of work on using legal methods to increase access to abortion. So if nothing works out, then we are planning to file a PIL in the Supreme Court, asking the Supreme Court to tell the center to establish boards. Whenever we talk to the center, they say, oh, COVID, but now I think COVID is almost, hopefully, almost over. And hopefully they'll get around to setting up the gazettes and then the boards will be formed.
Another question is regarding issues of Isopprostol. Everywhere medical or medical back.
Yes.
So it has become always
Yeah.
This is very complicated.
So, sir, actually there are laws to deal with it already. The government's not implementing them. And that really is not something which medical associations should get into. I think that when you talk about abuse of misoprostol, perhaps we also need to consider what are the alternatives to women who don't have access. See, ultimately, only women who don't have access to qualified providers, they go to the pharmacist and take mifepristone and misoprostol. So if you think of it that way, and this is like a very broad kind of a public thinking, I'm not saying it's right, but it is an argument that can be made that if you look at that woman's alternatives, it is one, go to the pharmacist, take mifepristone and misoprostol. The other alternative is go to an unsafe provider and get a stick put into her uterus, or vinegar oil put into her uterus, or sometimes even hot oil poured in the vagina. You know all the methods of unsafe abortion. I saw a video clip recently where a woman somewhere in Jharkhand, I believe, put a stick in wet mud and then sat on the stick so that the stick entered her vagina and she thought it will go into her uterus and she'll abort. And so we have to balance these two things. Is that safer, getting sticks and stones put in the uterus, or is it is unregulated use of mifenyz better for the woman? I'm not talking about the law and all that. So I think perhaps the government takes that point of view and doesn't regulate on it. I don't know. I'm not saying whether it's right or wrong. I know that there are accidents which happen because of, you know, inappropriate dosing and so on and so forth. But I think, you know, as of now, there's already a law which exists, and that law has simply to be implemented.
I have a question about medical board. So if any doctor approaches medical board and a medical board is formed and there is a dispute,
Yeah.
there are 4 people, 3 people say that okay,
Yes,
but
yes.
majority say no.
Yeah.
What the doctor should do?
Okay, that's a very good question, madam. The answer is that the obstetrician is the leader of the board. And there was a lot of discussion about this. You know, we discussed about how many people should be on the board. Some people were saying that there have to be pediatric cardiologists on every board, a pediatric nephrologist on every board. I said, then you'll land up with 10 boards for the whole country. You, on the one hand, you're saying every district should have, then you want such subspecialists. I said, where are you going to get these people from? So that's why they said 3 people. And I said that they wanted a bureaucrat to be in charge of the board. I said, no, the only person who's qualified to decide whether that abortion can be done or not, both in terms of the indication as well as in terms of the procedure, because the indication is one part, but the board also decides whether woman can safely undergo that abortion. So the only person who's qualified to do that is the obstetrician. So the obstetrician is the leader of the board. In case there is any dispute, it's up to the obstetrician to decide yes or no. Yeah.
How long they should take? You say they apply.
3 days. 3 days to give an opinion. So if they apply on, say, Monday, then Monday, Tuesday, and Wednesday, and Thursday, the opinion has to be given. And Thursday and Friday, if the answer is yes, and by Saturday, the abortion has to be provided. That's very, very clear, very explicit in the rules.
Few questions on your previous.
Yes, ma'am.
talk. First question. Those of students for Olympia are in the details of for IVF cycles.
So for IVF cycle, sorry, IUI. So first of all, you only use it if the previous cycle has shown a shorter luteal phase. And if there has been a shorter luteal phase, the dose we use for IUI cycles is 2 mg BD. And I generally use estradiol valerate. So if you have had a luteal phase which is shorter despite progesterone and you started estradiol, you continue the estradiol till at least the heartbeat is seen. Yeah. No, from beginning of, from 48 hours after trigger till the heartbeat is seen. Yeah. So, well, that's a whole other discussion. Can I take 2 minutes to talk about that? So your question is about thin endometrium, and you started estradiol for thin endometrium. And the question is, how long should you continue? The answer to that is, don't start estradiol for thin endometrium because it doesn't help. Thin endometrium results from either a endometrial pathology, or the other reason is that there is inadequate estradiol in the body. Endometrium is the target organ of estradiol, which is produced by the oocyte, right? If there is no uterine pathology and the endometrium is thin, it means that your oocyte quality is either not good enough or the oocyte is not producing enough estradiol. Giving exogenous estradiol will increase the thickness, but it will not increase the number of receptors and pinopodes which are ultimately responsible for implantation.
The quality of the oocyte.
Yes. So focus. So if you have done a hysteroscopy, ruled out endometrial pathology, improve your stimulation. It will automatically improve your endometrium. And there is, of course, this whole theory of how important endometrial thickness really is. That's a very basic question. I'll just give you a hypothesis. We were using clomiphene citrate. And when letrozole came, they told us that letrozole is better than clomiphene citrate because letrozole produces thicker endometrium. And all the studies have very clearly shown that letrozole produces thicker endometrium, right? Then pregnancy rates with letrozole should have been better, no? But they are not better, right? So if they are not better, then that means one out of two things. One, either the effect of clomiphene on the endometrium is not as bad as we thought it is, or endometrial thickness doesn't matter. Those are the only two options.
Or letrozole is monofollicular.
Huh?
It is multifollicular.
No, letrozole in fact causes monofollicular development.
That's not correct.
Yeah.
Monofollicular, so
Yeah.
less chances. Clomiphene multifollicular, so
No. Multifollicular, more estrogen, the endometrium should be thicker, no? Because the endometrium is a target organ of estradiol. So these are the two conclusions. So either endometrium doesn't matter, thickness, or the effect of clomiphene on endometrium not as bad. And now there are a whole lot of papers to suggest that it's not the thickness which is important, it is the pattern of the endometrium which is important. So it's better to have a thin triple line endometrium rather than a thick homogeneous endometrium. Okay, so don't only look at the thickness, and certainly don't use estradiol for thickness, it does nothing to it. It's different in IVF cycles. Those are down-regulated cycles where you are doing a thaw transfer or you're doing a transfer for recipient. There, of course, you need to use it. But then over there, there's no endogenous estrogen. So there's a big difference.
okay.
So 10 milligram BD.
BD for like
Till as long as you want to continue.
14 days or
So if she gets pregnant, I give it up to 12 weeks.
husband is sending her only 40 days, she should keep it.
No, I give it for 18 days after I start, because normally that will correlate with the first day of the last menstrual period. You see, normally, yeah. So I give it for 18 days, and then I do a urine test. Yeah. Okay. It depends on which side of the Atlantic you are in. This is where there is a difference between the European and the UK guidelines and the American guidelines. The American guidelines say that, so the UK or the European, the UK guidelines say that you can do parental karyotyping after 3 losses. And the European and the American guidelines say that you can do parental karyotyping. However, the only reason to do it is for explanatory purposes. Unless there is an obvious chromosomal translocation or rearrangement of some sort, or there is a syndrome detected of some sort, parental karyotyping has no role to play in RP. So,
Parental karyotyping is more simpler than parental karyotyping for products of conception.
so you're not supposed to do products of conception karyotyping also. Because again, and this is from the Royal College guidelines, they say that if a patient has had more than 3 abortions, then you do a POC karyotyping. However, you don't do it for diagnostic or therapeutic purposes. You do it to offer what I think the new generation calls closure in terms of an explanation of why this happened. But it won't help you to prognosticate on the future because of 2 reasons. One reason is that the incidence of sporadic mutations, which occurs in women with recurrent pregnancy loss, when it is stratified by age, it's actually lesser than what occurs in normal women, right? And secondly, it is a well-known fact that a large number of abortions per se occur because of aneuploidies, right? But not recurrent losses. So an isolated abortion can be because of a abnormal karyotype, but the second or third may not be because of the same abnormal karyotype. And in fact, there is no link between the two. That is why karyotyping of products of conception is not recommended routinely. It's only recommended when the woman or the couple would like to have some form of emotional closure and or an explanation.
They keep asking.
They keep asking. So if they want it, you do it.
And
But
they have different blighted ovum or the
Yeah.
less than 6 weeks abortion.
so, madam, for a blighted ovum, actually, karyotype is of absolutely no use
No, sir.
because you won't get only anything growth in the culture.
No, sir, like they keep asking what else to do.
Yeah.
So it-
So my approach to RPL is very simple actually. I screen for uterine anomalies and I screen for antiphospholipid antibodies. That's all. I really don't do anything else.
Me, sir, but when you do extra, I tell everybody to do
Yeah,
karyotyping.
exactly.
It's only for knowing the reason.
Correct.
And we
Absolutely.
can't just that the good gene has to go to this
Yes,
baby. Everybody will
absolutely.
become pregnant. Do
Absolutely.
a genetic testing, then confirm that good doesn't continue.
Yes.
So no quantity, but still they keep on asking.
They keep on asking. So you do it for explanatory purposes, but don't expect anything great medically out of it.
Okay, thanks.
Yes, ma'am.
Sir, this on the MPP Act. So there are certain things we'd like to clarify. One is that, as you said, the law comes from the central government and then it has to be implemented by the state government.
No, it doesn't have to be implemented. The act and the rules are a central act and a central rule where the state government has to take no further step for implementation. All states, it is implemented only. Only the regulations have to be accepted or adopted by the state. The act and the rules are a central act, no?
So do we have to wait for the state to actually adopt these, the amendments of the
No,
act?
no, no,
We
no.
can go ahead.
You can go ahead as of this moment, as of
Another one is
October.
talking of the SOP.
Yeah, but that's not come out yet.
So we don't have to wait for any of those.
So you can make your own internal SOPs, but the SOPs which the central government will make will be the ones which will be taken by everybody. Yeah.
Any questions from the postgraduates? Okay, shall we conclude now? So we are extremely happy and to listen to you and thank you. You traveled a lot and still waiting to visit.
Thank you so much.
Thank you.
Thank you, ma'am.
Thank you, sir, for your insightful and enlightening lecture.
Thank you.
I thank Dr. Vidya Topi ma'am and Dr. Shailaja Inaugural ma'am for chairing the session. And I request our chairpersons to hand over the e-certificate and bouquet to Dr. Jaideep Tang sir as a token of respect and appreciation.
So that is the digital certificate, right? Yes. We have learned a lot from digital things from our certificate. It will be sent to your email.
Shri, one second.
Yes.
Now I request Dr. Neelama Patil ma'am to hand over e-certificates and bouquet as a token of respect for our chairpersons today.
It has been a very interactive session this morning, and I thank all the guests for today, especially Dr. Jaideep sir and Topi madam, Muthu sir, Vidri madam, Shailaja Inaugural madam, and Jayashri madam, and Jaju sir who all came and blessed our CME. I also thank our speakers, Dr. Shobha madam and Dr. Vidri madam, who also contributed a lot for the CME. And our IT coordinator, Dr. Preeti Malpure, and Shri Kori, who was taking care of the catering. Unfortunately, she could not join us. And Dr. Salmesh Matpati, who looked after the inaugural ceremony. I'd also give a big thanks to the IT department and Chirag, who has been taking a lot of photos. So thank you one and all. And now we can proceed for lunch. Thank you.